a relatively long subject, but very important subject, which is ventricular tachycardia. If you look at this electrocardiogram, this is a wide complex tachycardia. The essential three differential diagnosis is ventricular tachycardia, number one, and number two, supraventricular tachycardia with ablation or fixed bundle branch block, and number three, antidromic tachycardia, that's a pre-excitation syndrome with conduction across the axillary pathway. The latter is easy to exclude. If you look into V6, the electrical activation of the ventricle is moving away from the apex. So that excludes pre-excitation syndrome because there is no accessory pathway that gets inserted into the apex of the left ventricle to allow the excitatory wave to move away from the apex. So QS in V5 and V6 excludes a pre-excitation syndrome, and therefore antidromic tachycardia can be easily excluded. Now, to differentiate between ventricular tachycardia and supraventricular tachycardia with aberration, first of all, look to the underlying etiology. If you have a structural heart disease, then the possibility that this is ventricular tachycardia is over 85%. If the structural heart disease is ischemic heart disease, the possibility that this is ventricular tachycardia is over 95%, without going into any morphological or electrical differential diagnosis. If you are still confused, then you start to look to the electrical the differences between supraventricular and ventricular tachycardia. Now, if you look into V1, this is a typical right bundle branch block because the initial R is wider and the QRS complex here, if you calculate it, it's 0.22. Anything right bundle branch block about 0.14 of a second is in favor, but not diagnostic of ventricular tachycardia. Additionally, if you look into the axis in the frontal plane, it's a northwest axis, very unlikely to be supraventricular tachycardia with aberration. So looking to the underlying etiology is very important. Now, if you look into what are the main differentiating points between supraventricular tachycardia and ventricular tachycardia, AV dissociation has a specificity of almost 100%. A specificity of 100% means that the false positive result is zero. It is difficult to see because its sensitivity is only 10%. A surrogate of AV dissociation is the presence of capture and fusion beats. If you look into the upper panel on the right, this is a capture beat. And if you look into the lower panel on the right, this is a fusion beat. These are surrogate electrical activity of AV dissociation. So if AV dissociation is very unlikely to be supraventricular tachycardia with aberration. There is nothing impossible in electrophysiology. Electrophysiology is a branch of science of exceptions. And for every exception, there is exception. The second thing, a northwest axis, which is an axis located in the upper left right quadrant in this area. I hope you can see the arrow here. And if you transect the right bundle, you get the QRS complex less than 140. So if it's more than 140 and the right bundaloid in morphology, this is in favor of ventricular tachycardia. If it's left bundaloid in morphology, then 160 is the cutoff point. If you are still confused and you have the luxury of having a 12-lead electrocardiogram, then you study the morphology of the V1, and that's the most important thing. To look for AV dissociation, the classic teaching is to look for lead 2 and V1. But over the year, I found that if you look into the lead with the narrowest QRS complex, you will get the widest ST segment. If you compare the ST segments of the subsequent beats for a sharp deflection must be a P wave. So that's the easiest way. Look to the 12-lead electrocardiogram, find out where is the narrowest QRS inspect the ST segment, compare the ST segments with each other, look for a sharp deflection. If there's a sharp deflection like those pointed to by the arrows, these are P waves. If the V is more than the A and there is no link between the A and the V, that's AV dissociation, 100% specificity, 10% sensitivity for the diagnosis of ventricular tachycardia. Now, the Brugada criteria, you need to have a 12-lead electrocardiogram to implement it, and you need to memorize it. So that's the difficulty. Now, first step in Brugada criteria is to look for a transitional zone, an RS complex in the precordial leads. If there is no transitional complex in the precordial leads, this means that you are dealing with ventricular tachycardia. If there is a transitional zone, then you move to the next step and you measure the interval from the beginning of the QRS to the nadir of the S wave. If it's more than 100 milliseconds, that's ventricular tachycardia. If not, you move to the third step, which is AV dissociation that I just explained before. If not, then you go to the morphologic criteria, which I will detail in the subsequent slide. You look for V1 for the typical left bundle branch block pattern or the right bundle branch block pattern. If you look into the square in the left lower corner, the lower panel will tell you how the typical left bundle branch block pattern reveals itself. An initial narrow wave, the R wave, and then a sharp downward deflection, and then an S wave, which is not very wide. If the initial R wave is more than 30 milliseconds, if there is a notch on the descending limb of the RS wave, and if the duration of the RS interval is more than 60 milliseconds, this is in favor of atypical left bundle branch block, and a wide complex tachycardia of this nature will be a ventricular tachycardia. If you look into V6, then you don't get a Q wave at the beginning of the left bundle branch block morphology. If you get a Q wave, this means that there is a septal infarction or fibrosis, and this means that there is a structural heart disease. So a wide complex tachycardia will then be a ventricular tachycardia. Now, if you look into this electrocardiogram, 12-lead electrocardiogram, concentrate on V1, wide complex, initial R is wide, the descending limb of the QRS is notched, so that fulfills the criteria of the atypical left bundle branch block, and hence this wide complex tachycardia is a ventricular tachycardia. Now, if you look, what is the typical right bundle branch block? It's an RSR' in V1, as you see in the upper panel. But if you look into the lower electrocardiogram V1, it's totally abnormal. If you look to the monophasic downstairs here in this panel, any single R wave or a QR or an RS or an RSR' with the left rabbit ear higher or more prominent than the right rabbit ear, if seen from the rear. If you look from the back of the rabbit, you see the left rabbit ear higher than the right rabbit ear. These are typical for atypical morphologies of right bundle branch block and a wide complex tachycardia with V1 showing this morphology connotes the presence of a ventricular rather than supraventricular tachycardia. Why we are concentrating on all of these things? Because the electrophysiologists like to localize the origin of the tachycardia in order to ablate it in case drug therapy is not tolerable, undesirable, or failing to achieve its objective. So the first thing is drug therapy, and ablation for atrial fibrillation and ventricular tachycardia always come next to drug therapy if the drug therapy is either failing, intolerable, or undesirable. Now, you know that the two ventricles are an anterior ventricle and a posterior ventricle. If you get an electrical activity arising from the anterior ventricle, whether from the free wall of the right ventricle or from the interventricular septum, with the exit on the right side of the septum, then it will show a left bundle branch block morphology. It means that it will be predominantly negative complex in B1. If you have a posterior ventricular origin of the tachycardia, free wall or an exit from the septum towards the left side of the heart, then you will get a right bundle branch block pattern that's a positive deflection in B1. So this is the first step in localizing the origin of the tachycardia. Now, if you have one single event arising from the ventricle, that's a PVC. If you have three at a rate of more than 100, this is a non-sustained ventricular tachycardia. If the non-sustained lasts for 30 seconds or more, or is hemodynamically significant, then this is sustained ventricular tachycardia, of which we have four types. Either it is of the same morphology, monomorphic, and this is usually scar-related, or it is ischemia-related, polymorphic, particularly in conditions of the channel locuses, or if it is bidirectional, and this is characteristic of calcium overload, essentially digitalis toxicity, catecholaminergic polymorphic ventricular tachycardia, or long QT7 or long QT4. Long QT7 previously was called Anderson-Towle syndrome. Now this is usually considered as a special entity away from the long QT syndromes. Now we can get a fourth type called the multiple monomorphic or pleomorphic. This is monomorphic ventricular tachycardia in series, but the monomorphic ventricular tachycardia takes bundles of different morphology. So you get some beats of the same morphology, then you get other beats of a different morphology, and so forth. So these are the four types of sustained ventricular tachycardia. Very important to differentiate because the underlying etiology is completely different, and hence the line of treatment and the strategy of management is completely different. How to treat a PVC? The first line is beta blockers or calcium channel antagonists. The absolute no, according to the CAST trial published several years ago, is to implement the use of 1C drugs, flecainide, 1-propafenone. This is absolutely contraindicated in patients who are having structural heart disease. So it's not to be used in the treatment of PVCs, particularly if you get a left ventricular dysfunction of an ischemic etiology. If you have an ischemic etiology or a left ventricular dysfunction, then the drugs of choice will be the class 3 antiarrhythmic drugs, essentially what is abbreviated by the word SAD. SAD stands for sotalol, adriamycin, and dofetilide. You have to be aware that sometimes the burden associated with too many PVCs, particularly if they exceed 10 to 20% of the total beats per 24 hours, then a PVC or tachycardia-induced cardiomyopathy can produce. Why is that? Because the PVCs will result in conduction disturbance and will result in impairment of ventricular function and may push the patient in heart failure, particularly those who are having a left bundle branch block morphology. Recently, it was shown that even 5% of the total beats per 24 hours, if they are of the ectopic in origin, they can still produce a cardiomyopathy. Now, the guidelines, I wanted to direct your attention to 2 or 3 points. Look at the end of these guidelines, a class 3 recommendation here. The class 3 recommendation here says a wide QRS complex tachycardia of unknown origin, you are not allowed to use calcium channel blockers. Why is that? Because as I said in the first slide, one of the differential diagnoses of these conditions is pre-excited supraventricular arrhythmia, and this pre-excited supraventricular arrhythmia may turn out to be atrial fibrillation. And if you block the AV conduction by calcium channel blockers, then the atrial fibrillation is very likely to change into ventricular fibrillation with its consequences. Now, if you leave the class 3 and go to the class 1, then for hemodynamically unstable ventricular tachycardia, everyone knows from the ACLS algorithms that direct current cardioversion should be implemented. But if the tachycardia is stable, then the drug of choice, according to the guidelines, is procainamide, which according to the 2017 guidelines is more effective in ablating ventricular tachycardia than amiodarone. Now, polymorphic ventricular tachycardia, if you see it, there are differential diagnoses for it, but the first and second and third cause of polymorphic ventricular tachycardia is ischemia. So ischemia, ischemia, and ischemia. If you get polymorphic ventricular tachycardia early within the first 48 hours of myocardial infarction, it indicates an initial in-hospital high mortality rate, maybe in the immediate post-hospital phase, but it's not a long-term mortality risk. So it's not an indication for ICD. You treat polymorphic ventricular tachycardia in the way you are doing your algorithm for ACLS. Shockable rhythm, choice of the drug, and cardioversion if needed. The other causes of polymorphic ventricular tachycardia include the channelopathies, which we are going to come to discuss in detail tonight, various drugs and electrolyte imbalance, and decompensated heart failure. We know that you cannot ablate polymorphic ventricular tachycardia except in one instance. And this one instance is that if you look into the lower panel, you will find that this polymorphic ventricular tachycardia is excited or incited by a unifocal PVCs. So these PVCs, particularly if they are early and they are producing an R or T phenomenon, they can be the inciting point of polymorphic ventricular tachycardia. If they are unifocal, then they are subjected to ablation, and this will be satisfactory treatment for polymorphic ventricular tachycardia. This is the only type of polymorphic ventricular tachycardia that is targeted for ablation. So shouldn't be mistaken. Now, polymorphic ventricular tachycardia, when it's associated with long QT, if you have the luxury of obtaining the electrocardiogram during sinus rhythm, is called the torsade de Pointes. It could be congenital, and I will explain it at the end of this lecture, or it could be acquired because of the variety of drugs. Now, all the drugs which produce long QT interval are antagonizing the IKR current. The IKR current, I stands for current, and K is the delayed potassium rectifier, and R is the rapid component of the delayed rectifier potassium current. Now, this is antagonized by infusion of magnesium. You might wonder why we are using the magnesium. It's a cofactor of the sodium-potassium pump. The magnesium deficiency, which is hard to detect from the serum magnesium because it's essentially an intracellular cation, and magnesium deficiency will produce partial depolarization, and you can block that by magnesium infusion. Now, this QT interval, which is prolonged as a result of drugs or secondary causes, is usually bradycardia dependent, in contradistinction to the congenital type of QT prolongation, which is tachycardia dependent. So here we try to increase the heart rate to diminish the dispersion. So you need, سمعني يا ياسر، التليفون ضرب. Hello? So you need, سمعني؟ So you need to give the patient magnesium. You need to increase the heart rate by isoproterenol, that's pharmacological pacing, or you pace the patient by a temporary wire, and you avoid bradycardia, which increases the vulnerability for producing an R on T phenomenon. Now, this is the pheochromocytoma of ventricular tachycardia, what is called the ventricular tachycardia storm. This is defined as 3 or more episodes of ventricular tachycardia within 24 hours. They can escalate into an incessant state that's life-threatening. The drug of choice is amiodarone. If amiodarone fails, then we can use lidocaine as a second line. You correct the electrolytes, you remove any precipitating drugs, and you reduce the sympathetic tone. And our 3 methods to reduce the sympathetic tone is beta blocker infusion, sedation and intubation with general anesthesia, and then in the field of neurocardiology, stellate ganglion blockade or thoracic epidural anesthesia, which is done by the anesthesiologist. And since ischemia is an eminent cause, cardiac catheterization looking for ischemia is important. You need to find out whether a single focus PVC is responsible for that. If that's the situation, you ablate the PVC, you continue the patient's life without antiarrhythmic drugs. So this is very important. Now we have various mechanisms for ventricular tachycardia. In patients who are ventricular tachycardia is the outcome of ischemia or of the Purkinje tissue or infarction, then the underlying mechanism is usually enhanced abnormal automaticity. In patients with long QT interval of the congenital variety, this is early after depolarization. In patients with calcium overload like dish toxicity, CPVT, and idiopathic PVC, which we are going to come to very soon, it's delayed after depolarization. And then we have re-entry, very common as a scar-related phenomena around the scar or around a natural obstacle, like in ventricular tachycardia, complicating the ischemic cardiomyopathy or non-ischemic cardiomyopathy, structural heart disease in general, or a functional re-entry taking the form of a spiral wave or a large wave with emanating small spiral waves, which we call rotors, responsible for ventricular tachycardia that might degenerate into ventricular fibrillation. Or we will explain Brugada syndrome. Brugada syndrome is essentially a dispersion between the phase 2 activation in the monophasic action potential between the epicardium and the endocardium of the right ventricular outflow tract. And the resulting re-entry is called phase 2 re-entry as a result of that. And I will explain it when we come to Brugada syndrome at the end of this lecture. If you inspect the time-honored classification of antiarrhythmic drugs, we are actually having 2 essential groups. Group 1, which is the sodium channel blockers, and this delay phase 0, which is the depolarization phase. And as a result of that, it widens the QRS complex. It's used when there is no structural heart disease, normal hearts. And the second important group is class 3, which is potassium channel blockers, which we abbreviate by the word SAD, sotalol, amiodarone, and ketolide. They block the potassium current, so they prolong the repolarization, they widen the QT interval, and they are used in patients with having a structural heart disease. So you are sad because you have a sick heart. So normal heart is indicated, we usually use essentially the sodium channel blockers, and abnormal or structurally abnormal heart, we frequently use SAD or the potassium channel blockers. Now, it is very essential at the very beginning of diagnosing ventricular tachycardia to ask and try to answer the following question. Is there a structural heart disease or not? Because that will divide the ventricular tachycardia into 3 groups. 1 without structural heart disease and carrying a benign prognosis. 1 with a structural heart disease and carrying a very careful and demanding workup and bad prognosis. And the third group is the channelopathy, structurally normal but still a malignant condition. And the way we find out whether we are having structural heart disease or not is number 1, echocardiography. If there are subtle abnormalities that cannot be detected by echocardiography, then cardiac MRI with the detection of delayed gadolinium enhancement. Now we have a CT with delayed iodine enhancement can replace cardiac MRI if there is a contraindication or a caution of doing cardiac MRI. If the patient is having sporadic symptoms associated with syncope that looks arrhythmogenic in origin, the patient falls and then comes up without any residua and unrelated to posture. This is the kind of syncope that's fearful, arrhythmogenic in origin. If the patient is having symptoms suspected of arrhythmia and syncope, then implantable loop recorder is our target in the investigation. If the patient is having a syncope and is having structural heart disease, but he didn't have an ICD, then this is a class 2 recommendation for doing an electrophysiologic study. So this is our plan in studying patients to diagnose whether they are having structural heart disease or they don't have structural heart disease. Now, if we started the first group of ventricular tachycardia without structural heart disease, in the presence of a structurally normal heart. Now, these are the two groups. A group in which there is no risk of sudden death, so this group is not an indication. As a matter of fact, is a contraindication for ICD, and a very rare group at risk of sudden cardiac death, and this is another situation. And the group without risk of sudden cardiac death and contraindication for ICD implantation includes idiopathic focal PVC and repetitive monomorphic ventricular tachycardia. 80% of these arrhythmias are arising from the outflow tract of both ventricles, essentially the right, and to a less extent to the sinus of Valsalva or the left ventricular outflow tract. These arrhythmias are usually due to triggered activity delayed after depolarization. They are exercise related. With exercise or sympathetic stimulation, you get activation of cyclic adenosine monophosphate, and this increases the calcium load responsible for after depolarization. And a high burden of this PVC can produce irreversible form of cardiomyopathy. And the second type of this relatively benign ventricular tachycardia is what we call Belhassen tachycardia, or idiopathic fascicular or idiopathic left ventricular tachycardia. Both of these conditions are benign conditions. They need ablation. They do not need an ICD. They very rarely result in sudden death. Very rarely you get a risk of sudden death, and this occurs whenever we have early coupled PVCs responsible for polymorphic ventricular tachycardia that I just explained a while ago, or the channelopathies, which are inherited arrhythmias, and we will explain to them. Now, this is a very important electrocardiogram. It shows a wide, complex tachycardia of the left bundle branch block morphology and in inferior axis. So the origin must be in the right ventricular outflow tract. Now, the differential diagnosis of this right ventricular outflow tract tachycardia includes the benign form of right ventricular outflow tract tachycardia. It includes ARVD, or arrhythmogenic right ventricular dysplasia. It also includes bundle branch re-entry and includes Magnesium pre-excitation for supraventricular tachycardia with aberration. Now, with Magnesium pre-excitation and bundle branch block re-entry, these patients are having a superior axis. Here, the axis is inferior. So this is in almost a diagnostic electrocardiogram of right ventricular outflow tract tachycardia of benign prognosis. This is very responsive to adenosine, which blocks the formation of the cyclic adenosine monophosphate, and that's the reason we are using adenosine in these patients. As a matter of fact, any antiarrhythmic drug is very capable of blocking this kind of tachycardia. So it's not only a benign tachycardia, but it also is very responsive to antiarrhythmic drugs. We rarely resort to ablation, although ablation is 100% or almost over 95% successful. The origin of this idiopathic focal tachycardia is the outflow tract of the right ventricle, less commonly the outflow tract or the aortic cusps on the left side of the heart. They might arise from the apical part of the interventricular septum or the aortomitral continuity. They can arise from the epicardial surface of the outflow tract, so their ablation should be done occasionally transpericardial, and they may arise from the papillary muscles. Now, the papillary muscle tachycardia is usually variable in morphology, subtle differences, and the ablation is difficult because of the complex three-dimensional structure of the papillary muscles. Remember that the idiopathic focal outflow tract tachycardia is a benign condition clearly associated with mortality, responsive to beta blockers, calcium antagonists, class 1C and class 3 antiarrhythmic drugs, and ablation is curable in 85 to 100% of these patients. So you need to identify it. Even more important but less frequent is the idiopathic left ventricular tachycardia or Belhassen tachycardia. This is not adenosine sensitive, this is verapamil sensitive. I call your attention that we do not use verapamil, particularly intravenous verapamil, in treatment of ventricular tachycardia because of the caution of having an pre-excitation in these conditions. This is the only one exception. So unless you are 100% sure of the diagnosis, don't give the verapamil. Now, this is a condition in which there is an area of Purkinje fiber disease. It's not an overt structural heart disease, but it's an electrical disease in the Purkinje fibers in the middle of the left side of the interventricular septum. And there is a re-entry circle here, which goes into a clockwise rotation, passing through the slow pathway in the Purkinje diseased fibers here, and then continuing into the posterior fascicle. So since it's arising from the posterior fascicle, it produces electrocardiographically a left anterior hemiblock. If you excite the posterior fascicle first, then it shows itself as right bundle branch block and left anterior hemiblock. And see, since we are moving here in the highway in the conduction system, the QRS complex will look narrow and will look very similar to supraventricular tachycardia with aberration. Narrow QRS complex, RSR dash of right bundle branch block, with the second rabbit ear or the right rabbit ear taller than the left rabbit ear. But if you look into the frontal leads, you get manifestations of left anterior hemiblock. Sometimes you get the reverse. You get the re-entry circuit into the anterior fascicle, and under these circumstances, you will get an ECG pattern still narrow complex, R with right bundle branch block, but with evidence of left posterior hemiblock. And sometimes you get a re-entry between the two fascicles, interfascicular tachycardia, but this usually occurs in the presence of structural heart disease rather than in structurally normal heart. So take a good look of this tachycardia. It's very similar to supraventricular tachycardia, but it has a specific etiology. It's a re-entry arrhythmia. It's verapamil sensitive, and as a result of that, you need to treat it with verapamil, or more appropriately with ablation of this area of slow conduction and less commonly of the posterior fascicle. You try to avoid inducing the left posterior fascicular block by ablating the slow pathway of the re-entry circuit of this fascicle. So Belhassen tachycardia not common, but common in examination, very common in examination. So to summarize the initial part of this lecture about the ventricular arrhythmias in the absence of structural heart disease or the presence of a normal heart, the two essential types, there are other types less common. The two essential types are idiopathic focal ventricular tachycardia, mostly from the outflow tract due to triggered activity. Ablation is curable, although it's responsive to all antiarrhythmic drugs, not associated with sudden death, and ICD is contraindicated. The other type of benign ventricular tachycardia is Belhassen tachycardia or idiopathic left ventricular fascicular tachycardia. It's a re-entry into involving the left posterior fascicle response to verapamil, but ablation is curative, and again, ICD is contraindicated. Now we move to the second part of ventricular tachycardia. Ventricular tachycardia in the presence of suspected or confirmed structural heart disease. How can we find the structural heart disease? Obviously by echo or by MRI. If the echo findings are not helpful, MRI will provide you with other added information. If you look to this arrow, it's pointing to subendocardial delayed gadolinium enhancement, which is pathognomonic of the presence of ischemia. If you look on the other side, on the left side of the cardiac silhouette here, this is a transmural delayed gadolinium enhancement, which is, speaks of advanced ischemic or a non-ischemic exhaustion. Now, the presence of the scar is very helpful because even if the electrophysiologist localizes the arrhythmia by any method, like activation mapping or pace mapping or substrate mapping or entrainment mapping, then the presence of the scar will help him to localize it. And if his localization matches with the location of the scar, that gives him more confidence that he is in the right direction. The VT morphology suggests the specific site of origin in these conditions, which usually corresponds to the type of the scar, and the scar morphology is an essential component of the circle, and it establishes the need for ablation in these circumstances. Now, this diagram illustrates up here the different types of the gadolinium enhancement in these conditions. You will find here the subendocardial enhancement of ischemia. If it's advanced, it becomes transmural. But on the right here, you have intramural or you have subepicardial late gadolinium enhancement, and this usually connotes the presence of non-ischemic cardiomyopathy. And the non-ischemic cardiomyopathy, usually the substrate for ventricular tachycardia is more prominent on the epicardium rather than on the endocardium. So if you look into this electroanatomical mapping, here the red corresponds to the scar, the purple corresponds to the normal tissue, and the other colors is the border of the scar. So if you compare the epicardium with the endocardium downstairs here, you will find that the scar is much more prominent on the epicardium than on the endocardium. So many patients with non-ischemic cardiomyopathy, you need to ablate on the epicardium. You can approach the epicardium through subxiphoid intrapericardial approach or sometimes through the coronary signs. On the right side here, you will get a study which was done several years ago. It was 22 patients. They were comparing ischemic with non-ischemic cardiomyopathy. And you will find that in 21 out of the 22 patients, the scar was epicardial rather than endocardial in patients with non-ischemic cardiomyopathy. So with non-ischemic cardiomyopathy, the scar is less dense, is patchy, is essentially subepicardial, is less on the endocardium, and the ablation is controversial issue, as we will see from some studies. Now, this is how monomorphic ventricular tachycardia gets generated in the presence of structure-related heart. You will get here the scar tissue, which is present in the white color here, and intermingled here and pierced with the scar tissue is viable myocardium. The word viable here means that it is conducting electricity but is not participating in contraction. And that gives the excuse for the electrophysiology to ablate everything here, not sacrificing the contractile power of the myocardium. Now, it is the differential repolarization here between the different arms of the re-entry circuit that is responsible for the re-entry. If you get the depolarization equivalent and the repolarization equivalent, the re-entry circuit will not occur. But as you see here, this is the subendocardial scar, and if this subendocardial scar has viable myocardial tissues conducting with differential refractoriness, and it is the differential refractoriness which makes the trigger, giving rise to a re-entry circuit around the scar. This is slightly different from the non-ischemic cardiomyopathy, where the scar is subepicardial, patchy, and not as clear as we find in ischemic cardiomyopathy. And this includes the following etiologies: dilated cardiomyopathy, Chagas disease in South America, sarcoidosis everywhere, hypertrophic cardiomyopathy, which we will highlight, congenital heart disease, particularly reparative lutology, ARBS, ARBD, or ARB3, which we will highlight, and other cardiomyopathies like left ventricular non-compaction. Now, before we finish with this ischemic etiology for ventricular tachycardia, what's the role of vascularization? In patients with ischemic cardiomyopathy, they are prone to sudden cardiac arrest, so these patients should undergo angiography, and this angiography will tell you whether there is ischemia or not. Revascularization should be done according to the guidelines for revascularizing occlusive lesions or occluded lesions. And then you wait 90 days for the myocardium to recover. Maybe you get up than 35%, which is the threshold for implanting defibrillators. And at the same time, don't expect it too much, because revascularization, the impact on monomorphic ventricular tachycardia, which is scar-related, is very little. So after revascularizing these patients, you still have some work to do. Find out where is the scar, where is the re-entry circuit, and you need to treat it. So it's a class 3 recommendation to think that the VT treatment by revascularization for ischemic cardiomyopathy is satisfactory. So we revascularize these patients, but don't expect that this will cure the large majority of patients with monomorphic ventricular tachycardia. That's completely different situation from polymorphic ventricular tachycardia, which I indicated that ischemia is the primary underlying etiology of these patients. Now, what's the long-term management of patients with ventricular tachycardia in the presence of structural heart disease? First of all, you assess the risk of sudden death and the need for ICD, essentially the ejection fraction below 35%. Antiarrhythmic drugs, including amiodarone, sotalol, mexiletine, although we know that although the mortality from arrhythmia decreases with these drugs, the total mortality does not decrease. So overall mortality does not decrease with antiarrhythmic drugs. But still, because ablation and other invasive measures is more drastic, then the guidelines recommend using drugs first, and if they fail or are intolerable or undesirable, then you move to the third step, which is catheter ablation. Meanwhile, you optimize the treatment of heart failure by using the various drugs we use in the treatment of heart failure. Now, using our criteria to identify people at risk, like ejection fraction below 30 or 35, or the presence of heart failure or previous cardiac arrest in these conditions, actually using this criteria, we identify only the high-risk individuals. And this constitutes, in the general population, the minority of the individuals. But if you go to the general population, you will find the large majority of patients having sudden cardiac arrest or having mortality from arrhythmia, they constitute a large number. But these criteria are not fit. You cannot get in the general population this criteria, nor the other criteria like signal average electrocardiogram, E-wave alternance, heart rate variability, carotid sinus responsiveness, or even the criteria risk factors for atherosclerosis or imaging. All of these failed to identify in the general population, which is the source of the large majority of sudden cardiac death population. So actually, our present criteria, which depends essentially on pump function to identify those at an electrical disadvantage, which is very distressing for every of us. And under these circumstances, we identify the minority of the people. We don't have, unfortunately, good indices by which we identify the large majority of patients with sudden death from the general population. This is called Meyer-Borg paradox after Robert Meyer-Borg, of Miami University. Now, the long treatment of ventricular tachycardia with structural heart disease, we said that. Now, what are the indications for ICD? For secondary prevention, there is no disagreement. If you get ventricular tachycardia, if you get sudden cardiac arrest, if you get ventricular fibrillation, they have three trials, the MUST, the CASH, and the AVID trial, all supporting the use of ICD in implantation. The problem comes with the primary prevention. The problem is partly solved in patients with a previous myocardial infarction because all the studies are consistent that if you get an ejection fraction below 30 or 35 under certain circumstances, then you get benefit from an ICD implantation after 40 days from the occurrence of myocardial infarction. The problem is bigger in patients with non-ischemic cardiomyopathy because if you look into these three studies, the first study supports the use of ICD in patients with a low ejection fraction, but the other two studies are negating that. So we have discrepancy in ideas, in views about the use of ICD in non-ischemic cardiomyopathy, no uniformity of thoughts about that. But generally, we use an index of pump function rather than an electric index to identify people who are indications for ICD. Meanwhile, we are confident for secondary prevention. We are a little less confident in patients with primary prevention. Now, catheter ablation is usually used for symptomatic patients when medications are not effective, are not desired, or are not tolerated. They are curative in idiopathic ventricular tachycardia, the two types that I alluded to just a while ago, without the presence of structural heart disease. But catheter ablation is adjunctive in presence of structural heart disease, typically in association with ICD and antiarrhythmic drugs. And this is a study, a Canadian study called the VANISH study published 4 years ago. And it was comparing that if the patient doesn't tolerate or is not responsive for a single antiarrhythmic drugs, do you escalate the antiarrhythmic drug therapy or you move to ablation? And you will find that the triple outcome of shocks, storm, and mortality was less with ablation rather than with escalation of antiarrhythmic drugs. So if you fail with one drug, you are very prone to fail with other drugs. So don't escalate. This is a typical multiple choice question. You are given different choices. Do you increase the drug? Do you increase loading of amiodarone? Do you add nexaritine or you ablate? The answer is ablate because of the VANISH trial published 4 years ago. Now, the guidelines recommendations for the treatment of ventricular tachycardia in ischemic cardiomyopathy is summarized on the right here. First of all, we use drugs, amiodarone or sotalol. If not, catheter ablation. Avoid 1C because they are not used in structurally abnormal heart. And remember that revascularization by itself is not sufficient to treat monomorphic ventricular tachycardia, which is scarring. Now look at this ECG. This ECG we used previously several years ago to consider it normal, particularly if you know that the patient is relatively young. And at the same time, we were connoting the word geopenial pattern to explain the T-wave inversion. Now the situation is different. Now, if you look carefully, the T-wave is inverted in V1, V2, and V3. But there is another abnormality in the electrocardiogram. If you compare the QRS complex in the right precordial leads with the QRS complex in the left precordial leads, there's a difference. If the QRS complex is wider in the right precordial leads, you ought to think of arrhythmogenic right ventricular dysplasia. This is an equivalent to the epsilon wave, which is present only in 30% of these patients. Now, the arrhythmogenic right ventricular dysplasia is a disorder of affecting essentially the right ventricle. It might involve the left ventricle, but less frequently. It's characterized by fibrofatty replacement of the myocardium, involving the basal as well as the apex and the right ventricular outflow tract, going from the epicardium towards the endocardium. It's a disease of the desmosomes with mutation of desmoflaccin, placoglobulin, placophilin, and others. Remember that it passes into different stages. The first stage is a concealed stage without electrical or functional abnormality, so that these patients might present by sudden death. And then they move into another phase characterized by electrical and sometimes functional abnormality. Ventricular tachycardia, since it's rising from the right ventricle, it's of the left bundle branch block morphology and is triggered by exercise. And the patient might advance to progressive right ventricular failure as time passes by. Now, the Hopkins criteria establishes the presence of major and minor criteria. You don't need to remember these, but remember only that the major criteria revolves around imaging criteria, which concentrates on right ventricular outflow tract dilatation, dyskinesia, and aneurysm formation, and electrical criteria in the form of T-wave inversion in the right precordial leads, with or without right bundle branch block pattern. ECG might reveal the epsilon wave, which is the delayed depolarization. You see it here in the left lower quadrant. You get the delayed depolarization of the right ventricular outflow tract, and you get ventricular arrhythmias. Since it's from the right ventricular outflow tract, it has a left bundle branch block morphology. If it is of superior axis, this is a major criteria. If it's left bundle branch block with inferior axis, it's a minor criteria. And then family history in the form of first degree relatives having the disease or a pathologic mutation, including the desmoflaccin and the other mutations. If you have it in a second degree relative, it's a minor criteria. The minor criteria are very similar to these, but less intense. But they include as well signal averaging electrocardiogram. Now, if you have two major or one major and two minor or four minor, that establishes the diagnosis. But one point of the caution is that you might get an electrical concealed condition with the first presentation in the form of Now, if you look to the right here, you will find that the scar is essentially epicardial. Fatty infiltration is essentially epicardial. It infiltrates the right ventricular outflow tract, the base of the right ventricle. This is an autosomal dominant condition. It can present in association with palmoplantar hyperkeratosis and woolly hair as a nexus syndrome. Carvajal syndrome is woolly hair and palmoplantar hyperkeratosis, but with dilated cardiomyopathy, not with ARVC. So the treatment is exercise restrictions and the avoidance of competitive and endurance sports. Beta blockers should be considered in all patients regardless of the presence or absence of arrhythmia. Ablation for drug refractory, which requires frequently epicardial approach, since the fatty infiltration and the scarring and inflammation is essentially epicardial. And ICD is indicated for secondary prevention, VT, VF, syncope, and in conditions of severe right ventricular dysfunction. Now we move to the other type of cardiomyopathy, hypertrophic cardiomyopathy, very eminent cause of death in athletes or young age in the general population. Now, who requires an ICD? For secondary prevention, there is no disagreement. Patients with sudden cardiac arrest is a class 1 indication of patients who have sustained ventricular tachycardia. Secondary prevention, essentially these 4 conditions: family history of hypertrophic cardiomyopathy, syncope, which is arrhythmogenic in origin. When we talk about syncope in this context, we talk about syncope which occurs suddenly without prodroma and without sequelae and without relation to posture. So syncope which occurs within the last 6 months, unexplained or looks nasty in origin, arrhythmogenic in origin, this is the kind for which we think about ICD. Non-sustained ventricular tachycardia, if it is repetitive, and particularly if it is associated with other risk factors. Otherwise, we'll end up putting ICD for so many patients because non-sustained ventricular tachycardia is very frequent in hypertrophic cardiomyopathy. And a drop of the blood pressure to exercise. If you are confused about the primary prevention, then you consider other high-risk features like a low ejection fraction, apical aneurysm, or delayed hyperenhancement of MRI. Left ventricular outflow tract obstruction is an added feature by itself, is not an indication for ICD implantation.
محمد وحضرتك ممكن تقلب السلايدز من السهم اللي فوق.
أنا هو السهم اللي فوق أهو.
دوس حضرتك عليه لغاية ما حضرتك توصل للسلايد اللي حضرتك عايزها. معلش دوس حضرتك عليه تاني يعني.
بحاول أعملها بكذا طريقة. So we move on to another situation, sarcoidosis. This is a condition in which the interventricular septum is involved like in hypertrophic cardiomyopathy. Remember that the interventricular septum is not involved in arrhythmogenic right ventricular cardiomyopathy and is not involved in left ventricular non-compaction. But it is involved in sarcoidosis as well as it's involved in hypertrophic cardiomyopathy. Remember as well, a family history is a risk factor in patients with arrhythmogenic right ventricular cardiomyopathy and also is a risk factor in patients with hypertrophic cardiomyopathy, but are not risk factors, only psychological risk factors in certain situations like CPVT and Brugada. CPVT and Brugada, the family history is not a rare risk factor, it's only psychological risk factor. So sarcoidosis is a condition in which the interventricular septum is predominantly involved and it's associated with the development of heart block and ventricular arrhythmias. So whenever you think of sarcoidosis, don't put a pacemaker, you put an ICD because And for ventricular arrhythmia, we use steroids as an antiarrhythmic drug in this condition. We use also the antiarrhythmic drugs. We might use ablation if it is incessant arrhythmia and refractory to immunosuppression and antiarrhythmic drugs. And the ICD is indicated if there is cardiac arrest, ejection fraction is low, if you need permanent pacing, or there is arrhythmogenic syncope that cannot be explained otherwise, or you have an easy induction of sustained ventricular tachycardia. Other cardiomyopathies that are associated with ventricular arrhythmia, including amyloidosis, left ventricular non-contraction, Chagas, lysosomal storage disease, muscular dystrophies, and the lamine A1C arrhythmia. So, a summary of the second part of the ventricular arrhythmias that complicate structural heart disease, consider non-ischemic cardiomyopathies, and we concentrate on management of the store of ventricular tachycardia, Consider monomorphic ventricular tachycardia if they have a re-entry around the scar, and polymorphic ventricular tachycardia, think about ischemia as the primary etiology and try to revascularize these patients. Now we move from this to the third type of ventricular tachycardia, which is really a nasty form of ventricular tachycardia, the channelopathy. They are uncommon, but they are very testable in the examination. They produce polymorphic ventricular tachycardia. And we will concentrate on the long QT interval, G-wave syndrome, which includes Brugada, early repolarization, and then CPVT and short QT interval. Now, how you measure the QT interval? You measure it by following the tangent and omitting the tail. What does this mean? Draw a tangent with the descending limb of the T wave until the tangent touches the baseline. This is the end of the T wave. Omit the tail, don't include the U wave except in one occasion, when the U wave is more than 50% of the height of the T wave. This occurs in one single syndrome, the Anderson-Towel syndrome, which is associated with dysmorphic features, as well as periodic paralysis. So unless you are thinking of Anderson-Towel by the presence of a very prominent U wave, don't include the U wave. Measure it in several leads, including V2 and V5. And if you have the corrected QT, corrected for the square root of the RR preceding the measure the QT's interval. So you measure the QT in one beat, go to the preceding beat, measure the RR, get the square root, divide the QT by the square root of the preceding RR to get the QTC. There are Patricia formula, but forget about it. This is the Bazet formula, which is applicable in most of the studies. If the QTC is more than 500 milliseconds without secondary causes, or if you are confused and you use the Schwartz criteria on the right side of the screen, which usually includes various degrees of QT prolongation, T-wave alternance, notched T-wave, syncope of arrhythmogenic origin, and family history, which is a real hazard in this situation. Or if you have a QT gene mutation unequivocal, then this is a definite diagnosis of long QT. If the QTC is somewhere between 480 and 499 milliseconds and is recurrent, repeatedly measured, and it proved to be in that range, and there is no obvious secondary cause, but there is an associated unexplained and suspected arrhythmogenic syncope, then this is a possible long QT syndrome. So, Among the different long QT mutations, at least 17 are known now. Number 1, long QT1, long QT2, long QT3 constitute 90% of them. Long QT1 is due to loss of function mutation of IKS, the slow component of the delayed rectifier potassium current. You can identify them without genetic studies just by looking at the ECG, characterized by broad, large T wave. And these patients are highly responsive to beta blocker, and the response of the polymorphic ventricular tachycardia associated with it is usually responsive to beta blockade. Long QT is due to loss of function of the IKR. Also, all the drug-induced long QT prolongation is due to inhibition of IKR. There is no drug that can inhibit IKS. There was one, but is no longer used at all. So IKR is responsible for long QT. Again, phenotypically, it's characterized by a low amplitude notched T wave. And these patients are modestly responsive to beta blocker, and the Torsade response is precipitated by auditory stimuli like the sound of a bell or a telephone bell, or the postpartum state. And then long QT syndrome, number 3, this is due to not loss of function, gain of function of the sodium channel, and this results in long QT3. And phenotypically, it's characterized by a long ST segment and a short, low voltage peaked T wave. And it is not responsive or minimally responsive to beta blocker, but is responsive to mixility. We have other long QT intervals. Prominent among them is Anderson-Tawil syndrome of long QT7, characterized by periodic paralysis and dysmorphic features, and the Timothy syndrome of long QT8, which is associated with syndactyly and learning difficulty. ممكن النهارده حكايه. What is the indication for genetic testing? Now, it's important to know that genetic testing is positive in about 2/3 of the patients, so it's actually very healthy. Class 1 recommendation for genetic testing includes strong clinical suspicion based on history, family history, ECG, and provocative tests like exercise testing with failure of shortening of the QT interval, or a previously done adrenaline testing aiming at the same thing. For asymptomatic individuals with long QT interval highly prolonged more than 500 milliseconds without a predisposing factor, or family history of a proband with well-defined mutation. Now, how we treat long QT? You avoid long QT syndrome. You avoid the QT prolonging drugs, so this should be identified and remembered very well. Avoid competitive sports, and then left cardiac sympathetic denervation if there is high risk the patient is at high risk and he is resisting the effect of beta blockers. Potassium infusion is variable in long QT2, which is due to loss of function of IKR, and mixilitine, as I said, is important in long QT3. So what's the indication for ICD? You cannot implant ICD if the patient is responsive for beta blocker, but it's indicated for cardiac arrest and syncope despite being on beta blocker. The two beta blocking drugs that are considered for this condition is Corgard or Nadolol, which was previously present in Egypt, no longer now, but metoprolol beta is present and is effective in these conditions. Now, acquired long QT syndrome is important to know the drugs which can produce that. It includes hypokalemia and hypocalcemia, fluoroquinolones, macrolide antibiotics, methadone, which is used for opioid addiction, loperamide, which is an antidiarrheal compound, several antidepressants, and antipsychotics. These are important, and as we said, these are bradycardia dependent in contrast to the tachycardia dependent congenital QT interval, so the treatment is different. Now we go to the J-wave syndromes. Brugada syndrome comes in 3 flavors. Type 1 characterized by ST elevation with a ski slope. You look at this arrow, the ski slope of the ST segment followed by an inverted T wave. In 2 of the 3 right precordial leads, V1, V2, and V3. This is type 1 according to the Heart Rhythm Association. This by itself is sufficient to diagnose Brugada syndrome. There is a lot of disagreement on this point because there are many experts in this field diagnose this as Brugada ECG pattern. This is the presence of symptoms to call it a syndrome. And this created a lot of problem about whether electrophysiological study should be indicated. Now it's settled on considering the electrophysiological study for asymptomatic type 1 Brugada syndrome. If they are asymptomatic, it's class 2B recommendation. Now type 2B and type 3, type 2 and type 3 are saddle-shaped ST segment with elevation of the J point 2 millimeter or more for type 2 and less than 2 millimeter in type 3. If you can change type 2 and type 3 into type 1 by either giving agmaline or procainamide or simply moving the electrodes from the 4th right intercostal space to the 3rd to the 2nd over the right ventricular outflow tract, if they change into type 1, you settle the diagnosis. So the diagnosis is essentially in type 1 with symptoms. So it's important to know that there are various precipitating factors of the Brugada syndrome. This includes sodium channel blockers, including some drugs like the tricyclic antidepressants. Fever also is a Brugada friend. These patients, they get a polymorphic ventricular tachycardia during sleep. Cocaine poisoning produces similar picture and it produces arrhythmia in patients with Brugada electrocardiogram, and the same with alcohol binges. Now the underlying mechanism for this is loss of function, not gain of function like longitudinal T3. It's loss of function of the sodium channel. So as a result of that, phase 0 depolarization is stunted. The second phase after that is the ITO, transient out current. It's normal or hyperactive, so it brings the action potential towards the 0 line and below the 0 line. And since this disruption of the electrical depolarization and the initial repolarization, the DOOM, which is the second phase of repolarization, is not well formed and doesn't allow calcium re-entry. Now this is heterogeneous because the ITO current is much more represented in the epicardium of the right ventricular outflow tract. So as a result of that, there is dispersion of refractoriness between the epicardium and the endocardium of the right ventricular outflow tract, and this creates what we call phase 2 re-entry, responsible for the polymorphic ventricular tachycardia. Again, the electric current produced by the dispersion of refractoriness between the epi and the endocardium of the right ventricular outflow tract is responsible for the ST elevation characteristic of type 1 Brugada syndrome. Now, how you treat Brugada syndrome? Avoid sodium channel blocking drugs, avoid alcohol, treat fever, and then quinidine. Quinidine doesn't act as class 1A antiarrhythmic drug under these circumstances. It's an antagonist to the ITO current, which overcomes the stunted phase 0 depolarization and produces failure to have the calcium DOOM of the second stage of repolarization. So quinidine is used under these circumstances. Isoproterenol is sometimes used to decrease the dispersion in refractoriness. But what is the indication of ICD? Cardiac arrest, spontaneous ventricular tachycardia, spontaneous type 1 ECG pattern with syncope. And as I told you, we have now indication for inducing the ventricular tachycardia and ventricular fibrillation, and during EP study in patients with asymptomatic type 1, and this is a class 2 recommendation, 2B recommendation. Previously, it was a controversial subject. And as I said before, family history here is just a psychological risk factor, not a true risk factor. So remember, CPVT, Brugada, family history doesn't matter. Now we move to CPVT, another very lethal arrhythmia. It is due to a leaky ryanodine receptor. The ryanodine receptor during the diastole is supposed to uptake the calcium from the sarcoplasm. Under these circumstances, it is leaky, and since it's leaky, it produces delayed after depolarization and ventricular arrhythmia. Now, this ventricular arrhythmia is usually related to exercise. You start the patient on the treadmill. After a while, he gets sinus tachycardia, and then he gets PVCs. PVCs comes in couplets, and after that, it appears. And it is bidirectional ventricular tachycardia, as you see in the right side of the screen. Extremely rare condition, but always think about it in patients with digitalis toxicity and CPVT. So you get bidirectional ventricular tachycardia. It's almost a diagnostic. The treatment of this condition is to limit exercise, beta blocker, and ICD for cardiac arrest and survivors or cardiac arrest survivors or recurrent syncope despite the use of beta blockers. Now, this is an autosomal dominant condition, but there is an autosomal recessive variant due to calsequestrine mutation, which is a protein which sequesters calcium in the sarcoplasmic reticulum. If it gets mutated again, calcium leaks in diastole, produces delayed after depolarization and the polymorphic ventricular tachycardia of CPVT. Highly lethal condition. You think of it when you consider long QT interval, you measure the QT interval and you find it normal. So where is the meat? The meat is the long QT interval. It's not existing, so consider CPVT. Another confusing issue is the early repolarization syndrome described by Hessager, and this early repolarization syndrome is characterized by a notch or a J wave at the end of the QRS complex, and the ST elevation more marked in the lateral precordial leads. Usually a benign condition, but we now recognize that some forms of it are highly malignant. How can you identify it? This is not clearly settled, but the only point that is accepted by most of people working in the field is that an elevation which is either horizontal or descending of the ST segment, particularly in the inferior and lateral leads, should be considered if the patient is having a cardiac arrest or survivors of syncope. Under these circumstances, you consider early repolarization syndrome. And the last syndrome that I want to talk to you, it's very rare, the short QT interval. You consider the QTC short if it's less than 360 milliseconds. It's due to gain of function of many of the potassium channels, and the kinidine might be protective under these circumstances. So, as I said, once we have ventricular tachycardia, we think about the three groups of etiologies, whether the patient is having a structurally normal heart, whether the patient is having a structurally abnormal heart, and if it is normal heart, is it the benign condition or the channelopathy, which is a malignant condition. And we discussed the channelopathies, including the long QT interval, the J-wave syndrome, including the Brugada and the early repolarization, the CPVT, short QT interval. All these put the patient at the risk of ICD, at the risk of sudden death, there are no indication for ICD in these conditions, and it's important also to exclude the drugs which prolong the QT interval and those which precipitate blue Garrison. So thank you for your attention, and I think Dr. Ahmed Al-Damati has something to say, and then we open the discussion and the question. دكتور ياسر.
مساء الخير دكتور محمد، مش عارف حضراتكم سامعيني ولا لا؟
سامع.
ازي حضرتك يا محمد، ونشكر حضرتك على المحاضره الكومبريهنسيف الرائعه كالعاده. شرف ليا ان انا اشترك مع حضرتك وكومنت.
الله يخليك، بس علي صوتك شويه.
تمام. كده احسن يا فندم؟
هايل.
If I may comment, I don't think I'm going to add much, but for patients with ventricular tachycardia and the no structure heart disease.
علي صوتك يا احمد عشان بيتقطع الصوت.
طيب انا هحاول اغير الكونكشن يا دكتور محمد.
يا ريت.
I hope this is a little bit better.
أحسن.
So I hope this is a little bit better.
أحسن كده أحسن.
تمام. So if I may give quick comments in patients with ventricular tachycardia and structure normal heart. ICD, as Dr. Muhammad pointed out, has no role. We go either for an ablation procedure, which carries a success rate in the range of 90% or more if done using an electroanatomical mapping technique, or in patients who do not prefer having an ablation procedure, or if the ablation procedure did not work out, we put them on medical treatment, taking in consideration that the prognosis of these group of patients is excellent and they have no risk of sudden cardiac death. On the other hand, in patients with ischemic heart disease, previous myocardial infarction, ICD is the mainstay of therapy. This is the only modality of therapy that is proven to prolong survival and prevent sudden cardiac death. Medical treatment like amiodarone or sotalol or catheter ablation only is used as an auxiliary treatment in those patients who remain having either appropriate ICD shocks or recurrent ventricular tachycardias despite the presence of the ICD. And as Dr. Muhammad pointed out again, in the VANISH study, we now have a clear guidance on whether to escalate medical therapy after having amiodarone on board versus ablation. So if you have a patient who is amiodarone naive, amiodarone is as good in controlling ventricular tachycardia as catheter ablation when you start. But if the patient already has amiodarone on board, escalating medical treatment through either increasing the dose of amiodarone or adding mexilitine is inferior to catheter ablation, and that's definite. So the success rate of this kind of procedure ranges in several studies across multi-centers in the world between 40% to 80% success rate. It's even better than patients with non-ischemic cardiomyopathy, where the success rate is marginally less. There are two main groups of patients with non-ischemic cardiomyopathy, of course, according to the pathology, but generally speaking, they are mostly DCM or post-myocarditis, and their scar is located in one of two locations. So an anteroseptal location or an infralateral location. So the infralateral location carries a better prognosis because it's accessible for ablation through an epicardial puncture. So you can easily tackle this substrate. That's why it's very important that you figure out beforehand with an imaging technique whether this substrate is an anteroseptal substrate or an infralateral substrate. The anteroseptal substrate patients has the worst prognosis because basically their scar is inaccessible. It's present in the septum and in the anterior wall, and it's very hard to ablate it, whether endocardially or epicardially, except using fancy techniques like bipolar pacing or bipolar ablation, or using two catheters, one at the side of each septum, or using a needle ablation. So this is for patients with structural heart disease. The other group of patients who are patients who have the channelopathies that starts with the long QT and goes across the whole spectrum that Dr. Mohammed presented. And it's very important to keep in mind that the classic agreement is on those patients who have secondary prevention indications. So those who get ventricular tachycardia, and that's a +1 indication for an ICD. The primary prevention indication is individualized according to the disease, and each patient has to be treated specifically according to his risk factors. Each disease has a group of risk factors that are cumulative, and you have to calculate the risk to be able to find a decision on whether this patient has an indication for an ICD or not. It's very important to realize that family history in some diseases, as Dr. Mohammed again pointed out, particularly Brugada syndrome, is a psychological risk factor rather than a true risk factor. So we should not go right away to the decision of an ICD implantation only based on the family history of sudden cardiac death. Having said that, this is a really tricky decision because if you ever face a family who lost a sibling because of sudden cardiac death, you find the conversation of not putting an ICD a bit tricky in order if you try to convince them not to because of the absence of clear benefit. And that I think would conclude my comments, and I would be happy to take any questions.
شكرا جزيلا للكومنتس الجميله كلها دي هايله.
شكرا جزيلا دكتور محمد. لو في اي اسئله I'm happy to share.
السلام عليكم دكتور محمد. دكتور احمد، انا محمد ثابت.
اهلا يا محمد.
اهلا وسهلا بحضرتك. وفي سؤال بيسال عن سؤال بيسال عن التايمينج اوف اي سي دي انديكيشن افتر كورونر ارتري ديزيز. هل بعد المايوكاردال انفاركشن wait for 3 months ولا 40 days؟
We will wait for 40 days after myocardial infarction. If you think that the patient is high risk during this period, there is a suggestion that the wearable defibrillator might help that. Patients during these 40 days, they don't die usually from arrhythmia, they die from complications of ischemia. So that's why you have to wait the 40 days. After revascularization, whether it's a procedural revascularization, catheter-based or cabbage, you should wait for 90 days. The problematic points, what about patients with myocarditis and cardiomyopathy? Still, you have to wait for a certain period, probably 90 days, in order to establish the diagnosis and exclude reversible things. So don't rush for these conditions, you have to wait. Definitely after myocardial infarction, you have to wait for 40 days and then evaluate the patient for the indication of ICD. You might be having an ischemic myocardial ejection fraction is 20, and after 40 days it came up to 40. So the patient is no longer an indication for an ICD. Unless if the patient is having ventricular tachycardia, this is not a primary prevention. That's the patient who can have an ICD even where the patient gets ventricular tachycardia after the first 48 hours. Some say 24 hours, but the guidelines say 48 hours. And then the patient gets ventricular tachycardia, or ventricular fibrillation, then he should not leave the hospital without an ICD. This is the minority of patients, but this is secondary prevention, and there is no disagreement about that. The 40 days is for primary prevention. But we can hear the opinion of Professor Ahmed Damati.
Dr. Muhammad, I totally agree. For secondary prevention indication, it's a straightforward. We do not wait. The only point that is controversial is the first 48 hours. The first 48 hours is classically considered a primary ventricular arrhythmias, and patients are not indicated for an ICD. However, we have to realize that this category of patients are not well studied, and perhaps they are at a bit higher risk than individuals who do not experience ventricular tachycardia.
Okay.
Up to this point in time, we do not have enough evidence to justify putting an ICD based on this only, but there is accumulating evidence that these patients might be at a higher risk.
Okay. No disagreement.
All right. So for a primary prevention indication, again, the first 40 days after a myocardial infarction and the first 90 days after revascularization, we have to wait to see whether the ejection fraction improves or not. Having said that, again, this period could be, patients during this period could be at risk of dying suddenly. That's why a wearable defibrillator is used in the Western community. Again, the data that we refrain from putting ICDs in this category of patients is based on the dynamite and the cabbage batch study, which did not show a long-term survival benefit. But we have to be cautious dealing with this group of patients and thinking that perhaps they are at a low risk. They are not, but we do not have an evidence that putting an ICD in this early period prolonged their survival long term. Thank you.
Okay, next question.
في سؤال بيسأل عن المانجمنت اوف channelopathy in pregnant females.
Malignant ايه؟
Management of channelopathies in pregnant females. هل في any precautions ولا هيبقى نفس المانجمنت؟
in malignant ولا pregnant female?
In pregnant females.
Pregnant female. I don't know any specific indications or contraindications in pregnancy. I think it should be the same unless the patient is using any of the drugs which can be responsible for the one of the channelopathy. So the patient is using antipsychotic drugs or using lithium for manic depressive psychosis. You should get out of the drug first and try to. But we don't use an ICD in these patients except for secondary prevention. We're usually very conservative. So we implement beta blockers for QT interval, even QT3, which is not very responsive with beta blockers for CPVT, and then we don't insert an ICD. Now, the main problem during the pregnancy is syncope. So syncope can be the result of compression of the inferior vena cava or as a result of the abuse of drugs that produce relative hypovolemia or a postural syncope. You have to make sure that the syncope is arrhythmogenic in origin rather than vasovagal or as a result of the compression of the inferior vena cava before considering it as an indication. But if you get cardiac arrest or you get sustained ventricular tachycardia, this is an indication for ICD implantation. نسمع برضه رأي أحمد الدماطي.
يا دكتور محمد I have nothing to add. يعني عدد المرضى اللي احنا بنستضيفهم بالكرايتيريا دي مرضى محدودين، فما فيش بيرسونال اكسبيرينس كافيه إنما based on the literature, we would do the same thing as we do for a normal patient. I would think that if a patient is controlled on a beta blocker, whether this is for long QT or CPBT, I would try to keep her throughout her pregnancy on the same medication. Thank you.
السؤال اللي بعده.
In case of ablation of scar-related ventricular tachycardia, is there a risk of affection of the ejection fraction if the scar is large?
طبعا احمد الدموية هو اللي هيجاوب السؤال ده, but let me try again. Now, originally you should target the isthmus, which is the area of slow conduction or the exit point. But I think they are no longer doing that. It's time consuming and is very laborious work. So they ablate everything. But I think the most of the electrophysiologists are very cautious to do to create too much scarring. So he wants to ablate the whole thing, including the scar and the viable myocardium interspersed in the scar, but at the same time not try to make too much scarring in the ventricular myocardium. The excuse is that if you ablate everything, then you are not sacrificing contractile myocardium. Anyhow, they have not been contractile at the beginning. They are conducting but not contractile. So I don't think that in the large majority of cases you diminish the ejection fraction, but if you keep ablating for a huge volume of scar and viable myocardium, definitely the ejection fraction is going to drop. The problem arises usually when you ablate certain areas, like the papillary muscles, for example. It's difficult. Usually you have different exits of the ventricular tachycardia, and you might create problems in the form of regurgitant lesions or similar condition. But let's hear the practical points Ahmed al-Damati is going to say.
Thank you, Dr. Muhammad. What I would say is that regardless the method that we adopt for ablation, be it activation, base mapping, or substrate modification, we still restrict our ablation points to the areas of scar. And scar only has a few surviving myocytes that won't affect the overall ejection fraction if it is ablated. We refrain from ablating healthy myocardium in patients with scar-related ventricular tachycardia, of course. This actually has been looked at in several studies. And even with extensive ablation that was limited to scar areas, there were no deleterious effects on the ejection fraction as long as you restrict ablation to the areas of scar. Thank you.
Okay.
Same applies to atrial fibrillation. But again, in atrial fibrillation, sometimes excessive ablation can diminish the emptying fraction of the left atrium. So they have to strike a balance between ablating everything that prevents exit of the premature beats or excitation from the pulmonary veins into the rest of the left atrium. Make sure that nothing goes from the inside the pulmonary veins to the left atrium, but at the same time not creating much scar to avoid decreasing the emptying fraction of the left atrium.
The next question بيسأل برضه عن secondary prevention post MR. Indication of wearable ICD during the first 40 days.
The wearable ICD is a controversial subject, but I think the last guideline is supporting using it within the first 40 days if you are worried about your patient, particularly those with very low ejection fraction. So if you have a patient that still didn't complete the 6 weeks of waiting for primary prevention, and at the same time the patient is having a lot of electrical instability and a low ejection fraction, this is the indication for the wearable defibrillator. Remember, the wearable defibrillator, you cannot take a bath with it, so sometimes it cannot be wear all the time, so that decreases its efficacy. But I think it's a class 2B recommendation to be used. It's more commonly used in Europe than in the States, but it has not been cancelled. It's one of the methods by which you can overcome the problem of the first 40 days.
If I may comment, Professor Muhammad, I think despite the fact that it is a bit lower class of recommendation classically, in the West, whenever it's available, they use it liberally as long as the ejection fraction is below 35%. But that's a good point to mention the few risk factors of those group of patients. What makes them more liable to develop VFVT? Those patients who have an ejection fraction that is less than 30%, or patients who have a worse Skillet plus, or those patients who develop primary VTVF are at higher risk, and you would put them a wearable defibrillator. This is the group of patients that you need to focus on if you're considering a wearable defibrillator. Thank you.
Next question.
بس كده يا دكتور محمد الاسئله خلصت.
طيب خلاص شكرا جزيلا.
شكرا دكتور احمد.
Next time will
شكرا
be
جزيلا.
Bloody arrhythmia as a pacemaker. شكرا جزيلا لكل المستمعين وكل الدكتور احمد الضماطي اسرع الدسكشن as I expected.
شكرا جزيلا دكتور محمد، سعدت بوجودي مع حضرتك.
سلام عليكم.
مع الف سلامه.
وعليكم السلام. شكرا.
مع السلامه.